But when I do have a patient of color, they're very grateful that someone has actually taken the time to explain to them what's happening. And you can see the gratitude, they express the gratitude. And for me, that's actually the best feeling, when I know that I have positively affected someone's life in that way, because it may not happen in too many other areas of their life where they are the star, they are listened to, and they're grateful, and it's a good feeling. It's a good feeling for me.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Erica Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello, and welcome to this episode of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart, and I have the pleasure of being joined by one of my college classmates and very seasoned and respected anesthesiologist, Dr. Monique King. Dr. King grew up in California, my native state, but a little bit north of me in Pasadena. She is a class of 1993 from Harvard University. She graduated from medical school at the University of Southern California in 1997. She did obstetrics and gynecology residency from 1997 to 1999 and anesthesiology residency from 1999 to 2002 at the University of Southern California School of Medicine. She is currently employed with an anesthesia group in Southern California and serves as the medical director of their outpatient surgical service. So welcome to UpMed, Dr. King.
Thank you so much, Erica. Thank you for giving me this opportunity to be here today and to talk a little bit about myself, my life, my career, and my thoughts on healthcare and medicine and anesthesiology today.
Absolutely. We are so happy to have you. And I forgot to mention that you are the mother of two beautiful young ladies, ages 17 and 14. So, Dr. King, I want to start with just a little bit of a reflection since I knew you when. I'm wondering if you could talk a bit about what motivated you to pursue a career in medicine.
Well, my thoughts about medicine came at a very early age. My parents emigrated to the United States from Guyana as adults, and I think there was always a very high expectation of achievement for both of their children. That's just me and my sister. There are just two of us. And I think that because I had two generations before me who were also physicians, I have an uncle and a great uncle. I had a great uncle who were both physicians. That was definitely something that, it was definitely an area of life, that an arena that I was exposed to. And, I think even as a young child, though, my mother always said, okay, Monique, you're going to be a doctor and your sister is going to be a lawyer. And that's kind of what was always told to us. And, being good children, we wanted to obey. And I
Yes.
just continued down that path. But I did start volunteering at a hospital probably about 14, the age of 14. And at that time, I had some exposure to anesthesiologists and what they did. And that is something that I set my sights on almost immediately. So I would say from the age of 14, I thought, hey, I think I'm going to be an anesthesiologist. This is going to be my calling in life. And I continued to pursue that. I think when it came time to actually choose a specialty, one of my uncles, one of the ones I just spoke of, said I shouldn't be an anesthesiologist.
Wow.
He said I needed to do something surgical.
Okay.
He said that there wasn't going to be enough. I think he didn't see it as having enough clout, enough respect. And there was always the threat of CRNAs or nurse anesthetists coming along. And he felt that my career path would certainly be shortened because they were going to use a lot more nurses to do this type of work. And I listened like an obedient child. I listened. And so, in my surgical rotations, I enjoyed surgery, but it wasn't something that I wanted to do all the time. So I thought about doing OBGYN, the combination of medicine and surgical procedures.
Yes.
I could be in the OR, but I also could see people in an office setting, deliver babies. I thought there was a little more variety there, something that would be more to my liking. And so
Yes.
that's why I did start the OBGYN residency, and I did 2 years of it. And at that point I said, this really isn't for me. This is not sustainable. And I went back to what I originally wanted to do, where my heart was. I'm a firm believer that people tend to do best in areas that they have where they have a passion. And so I went back and started with my anesthesia residency. I lost a year of residency as a result, but that was okay because in the grand scheme of things, that's okay. So it is okay to pivot, and I had to give myself that permission to pivot and make a different choice that was ultimately going to be to the betterment of my own future.
Yes, and that's a very courageous decision. I think as a woman, and then if we add the layer of being a woman of color in medicine, I wouldn't say it's an oddity, but that's not like the most common combination in the medical field. And when you embark on residency training, it is very sort of militaristic, military styled, in that you have a hierarchy. And within that hierarchy, there is a gist of having to prove oneself capable every day,
Yes.
consistently. And so, to be courageous enough to make that admission and then to actually execute the pivot is laudable, because that's not the path of least resistance.
Right.
I wonder if you can reflect a bit about maybe the personal qualities that you possess that allowed you to make that decision, and not only to make that decision, but to act on it decisively.
So I think that all my life I would characterize myself as an introvert. I am someone who has always been very much to myself, very introspective in a lot of ways. So I really felt I did a lot of introspection during this time, and I really had to examine my own true feelings, which is something that I think up to that time I hadn't really thought about too much, because I was so interested in pleasing my parents, my uncle and family, all these other people around me. I didn't always think about myself. And
Yes.
I think that that was one of the first times that I was able to dig deep, find some courage, and realize that it's my future. And despite what anyone else might think, I needed to do what was going to be best for me. So I think because I am someone who tends to really look inward for strength,
Yes.
that's where I had to find it. And it helped me not just to develop as a physician and to make that right choice for myself, but also just as a person and just with in other arenas of life, realizing that it's my power. I had to take back some control and some of my own power in my own life. And that was one of the first times that I was really able to do that.
Amazing. And what comes to mind for me as a question, especially if there are listeners who are thinking about career pivots or are thinking about making a jump, even within their specialty, is, did you have a mentor or even a sponsor that was able to help you through this process?
So I wouldn't really say I had a mentor per se. I would say that my uncle definitely served as the person who helped to guide my career and choices. And speaking about his life experience, the things that he had faced, the obstacles he had faced, I would say that probably influenced me the most. And I learned a lot from my peers. I mean, I would say, just to take it back a little bit, growing up, I always felt that I was somehow very different from a lot of my African American peers, my other Black Americans who, in my age group, and I always felt somewhat removed. I didn't feel like I had a lot of common ground for various reasons. I think a lot of that had to do with, the fact that my parents came from another country. I was very much raised in a Guyanese household, and there were a lot of exposures that I did not have in terms of Black American culture. And when I got to college and medical school, that was probably a time when, I started learning about, I had never heard of soul food before I got to college. so,
Wow.
so if that puts any perspective on
Mm.
it. um, and
Yes,
so
yes.
this process of learning about other Black Americans and my peers and learning from other Black Americans, I think that probably gave me more strength and influence than what I would say is a necessarily a mentor. I mean, these were exposures that really helped me to develop myself as a full and whole person and really opened my eyes to so much of what is out there in the world. I would say that my life was pretty sheltered growing up, and I think that learning from the people around me, the people in my residency, the people I went to college with, that was something that was really invaluable to me.
Mm, that is very insightful and very interesting, actually, to understand that African American culture is not monolithic and that there are lots of different perspectives. But to also hear that you say that culture enhanced your experience and gave you strength, I think that's definitely affirming. So, if we move along your path and we sort of skip a little bit forward, now that you're director of outpatient services, what was the journey to develop that expertise to then assume a position of leadership in that sphere of working with outpatients as opposed to patients that stay in the hospital with more, for lack of a better word, more severe or at least with disease processes that require longer term care?
Yeah, so when I in residency, my last year residency, I did an outpatient surgery rotation that was really, it was clearly a lifestyle choice for those anesthesiologists who did it. You didn't have to have the late nights, you didn't have to have the weekends. So, I mean, in some respect, that was initially appealing, but my professors and everyone around me always told me there is no way that you would ever do outpatient anesthesia. You live for the hearts, the vascular cases, all of that. Those bigger cases, they just couldn't see me ever doing that. And I at that time, I couldn't see it either. I needed to have that continued challenge. And so when I initially joined my group, that's what I did. I was a general anesthesiologist for several years. However, when I had my first daughter, that's when things changed. And I decided that I needed to try to balance motherhood and career in a way where I was not giving up too much on either end. And so that led me to think about doing outpatient anesthesia again. But in so doing, I really learned that it's not as easy and as simple as I think a lot of anesthesiologists think about it. I mean, there's really an art to it. There's a certain mindset that you have to have, and there's a certain way of doing things that I think are a lot different from what happens in the hospital. And so I just came to love it. I came to love challenging myself. When you're in the outpatient world, it's all about efficiency.
Yes.
You got to get people to sleep, have the surgery, wake them up. All of this has to happen very quickly. You want to have very little downtime between those cases. And that can be challenging for people who only work in the hospital because the hospital works at a much different pace. So, although people might see outpatient anesthesia as a nice cush life, yes, we don't have the late nights, we don't have the weekends. However, I would say we work a lot harder all day long than the hospital because we have to keep things going so very quickly. And there's really no time to waste. And if there is any sort of wasted time, everyone's always quick to say, "Oh, it's got to be the anesthesiologist's fault." it's,
Yes.
it's anything that's going wrong, it's got to be the anesthesiologist's fault.
Yes.
So you've got to have tough skin. You've got to learn to be fast. You've got to learn to be efficient. You've got to learn about those things that are going to be important to the patient, important to the surgeon, and important to the facility. And
Yes.
to make all those things work takes a lot, and it takes an art. It takes practice, and it was something that I really found that I excelled in.
That's phenomenal. It's not easy. And as you say, it's not for everyone. If I stand on the other side of the drape as the orthopedic surgeon working in the outpatient facility, I will say, yes, I am looking at anesthesia. I'm asking the question, why is this patient being put to sleep? This is a shoulder arthroscopy. Can't they, be awake? Why is this patient having to have an extra set of labs preoperatively when they have a medical clearance or risk stratification saying that they're cleared for surgery? Why are you doing this to me? So
Yes.
so I could quote your surgeon, colleague slash adversary, and say, that it does require a certain skill to keep everyone happy in this context. One of the questions I have for you that I alluded to was just that idea of when a patient is going to outpatient surgery, being able to assess a chart and determine that this patient is appropriate for outpatient surgery and making the appropriate accommodations. What's your philosophy with regard to that?
A couple things first. When we talk about outpatient surgery, outpatient anesthesiology, where I'm the medical director, it is actually an HOPD, or an hospital outpatient department, where we are operating under the license of the hospital, as opposed to a freestanding surgery center.
Yes.
With its own license, its own contracts. So we are actually physically located on the hospital campus. And because of that, we are afforded, I think, a little more leeway in terms of the types of patients and surgeries that we're able to perform. So when I'm making decisions based on an HOPD, I may be allowing that, BMI of, much higher than I might allow at, say, a freestanding surgery center, because I've got the hospital there.
Mm-hmm.
I know that we tend not to give blood at the HOPD, but we can do that. If it absolutely came down to it, we could do it.
Yes.
So we have a lot more freedom there. So those decisions are actually given a lot more leeway, and those patients are going to more resemble the hospital patients than a freestanding surgery center, where you want to make sure that their blood sugar is well controlled in a diabetic. You want to make sure that the blood pressure is controlled in a hypertensive. You want to make sure that if someone has renal failure, that they, and they're on dialysis, that they've gotten their dialysis that morning, and we've gotten some maybe post-op labs. Whereas at the hospitals, we don't have to be quite so stringent with all of our rules. But when you're in a freestanding surgery center, you've really got to make sure that these are relatively healthy patients. And if they do have medical conditions, that those conditions have been optimized. And
Yes.
knowing that anything that might happen, you want to minimize the chances of anything negative, obviously, any time happening. However, knowing that you can handle the consequence of that.
Mm-hmm.
When I'm at the hospital outpatient center, I know that we can handle it because I can call the pharmacy and the pharmacy will bring me my vasopressor, whatever I might need. But if I'm at a freestanding center, I can't always call for medications. I can't always call for lines. That's not something you're going to see done at an outpatient freestanding center. But if we needed to put in an A line, we could put in an A line. If we needed to put in central line, we could do that all at a hospital outpatient department. So I think having been the medical director at the hospital department, those decisions are not quite as difficult as it would be in a freestanding center. Most recently, I've actually been looking at some other freestanding centers and contemplating, changes in my career. And there's a big difference. There's a big difference. Things that you really have to be careful of when you know that it's you and only you. Even something as simple, I shouldn't say simple, but even a difficult airway, you're really going to question whether or not you're going to put someone to sleep with a difficult airway when you're at a freestanding center, especially if you happen to be the only anesthesiologist there at that time. Whereas if I'm at the hospital center, I can call my colleague who's, maybe on a break down the hall, who's going to come running to help. I can call the ENT who might be in the next room for an emergency airway. So there are a lot more precautions that you have to take, certainly in a freestanding center.
Yes, it's a challenge. And as I'm working on my avocation, which is sort of looking at the disparities in healthcare and trying to determine how we can alleviate some of those, as we look at the trends with insured patients versus patients with government assisted insurance, there is an association between the complexity of the patient in general and the type of insurance that they present with. Do you find that that adds another layer or another dynamic to your practice?
I would say that for me personally, it does not affect the patients that we treat. It does not affect who can come to the surgery center. We take all types of insurance. And there is that definite correlation. I think a lot of that, is lifestyle, preventative medicine. People with complexities tend to be people who don't see their doctor, who don't get their sugars checked to make sure that they're getting the right amount of insulin. And a lot of times, those people have other life concerns that for them seem more immediate and necessary than going to the doctor all the time. So, maybe that is your Medi-Cal patient who comes with complex issues that are uncontrolled, but I would say it does not affect who we treat or how we treat them.
Mhm.
In fact, a lot of times you do have to spend a lot more time with these patients with more complex issues. And I find that they are so grateful. They are so grateful for someone who will sit and talk with them and explain things. I think, particularly for patients of color, to be quite honest, in my practice, I don't have a whole lot, too many patients of color, but when I do have a patient of color, they're very grateful that someone has actually taken the time to explain to them what's happening. And you can see the gratitude, they express the gratitude. And for me, that's actually the best feeling when I know that I have positively affected someone's life in that way, because it may not happen in too many other areas of their life where they are the star, they are listened to, and they're grateful, and it's a good feeling. It's a good feeling for me.
Yes, I as I'm doing this more with the podcast, I am getting this answer, and that's a common thread through every interview. And you did allude though to one thing, which was that in the context of having increased complexity, then it does affect the time And as we open the podcast, time is money in, outpatient healthcare, be it office visits or surgery. So I wonder, how you are able to, or how one might be able to accommodate that adjustment factor, if you understand what I'm asking.
Yeah, sure. I mean, it's certainly challenging because you don't never want any patient to feel rushed.
Yes.
But there's always that element of time. Surgeons like, tapping their fingers what's going on, what's happening. But I think that honest, open communication with everybody involved is very important. So sometimes what I will do, I'll go to the surgeon. I'll say, hey, you know what? This is a little bit more complicated than I think we anticipated. Give me a few minutes, and then we'll be right in.
Yes.
Just so they don't sit there wondering what's going on. I think the open dialogue is very important. And I find that when I can do this, surgeons are very appreciative. The nurses in the room are very appreciative because I don't want anyone to wonder what's taking me so long. Why is this happening? I give everybody a heads up. I take the time I need because not only just to explain to the patient so that they feel good about what's happening, but also because you can't take good care of that patient if you don't understand everything that's happening with their medical condition. If you don't take the time to read that note from the cardiologist and truly understand what that heart condition is, you don't want to give a medication that could be disastrous for everybody involved. And then you really have to take a lot of time, energy, and resources out, in the system to care for this patient. So it's better to take those extra few minutes in the beginning than to end up regretting and spending hours, sometimes days, caring for a patient when it all could have been avoided. So
Yes.
I think open communication is the key.
Yes, it's the old cliche, right? The cliche that everyone knows, but it's rarely practiced these days, right? An ounce of prevention is worth a pound of cure. And it is very interesting, though, that we as medical professionals are experiencing the pressure of time. And much of what we do is not related to our training in the pathology or the pathophysiology or our expertise in our specialty, but is actually a byproduct of time management. And I wonder if you have a perspective on time from point zero when you started in anesthesiology in 1999 to point 2024. How do you view time? Same, different, in as an adversary, a friend?
Time is definitely not my friend. I'd like to say that we are, working on our relationship right now.
Yes.
Um, yeah, I think that, 1999 didn't have much of a concept of time. Time was sort of limitless
Yes.
from my perspective. And, I had all the time in the world to take care of patients, to have a family, to experience, things in life. Time, there was no end to it. There was no limit. Now, time is always on my mind.
Yes.
Always on my mind. I am, well, as I'm sure you are too, I mean, incredibly, incredibly busy. If I don't put something in a calendar and make sure that it's on there so that I get to it, it may not happen.
Yes.
I'm always conscious of, what time I would need to wake up in the morning in order to be there at a certain time. It's going to take me this long to talk to this patient. Then it's going to take me this long to actually do this block and then, get them in the OR. And so it's constantly running through my mind. And it's not only just for me, but it's the time management of my children as well. Making sure they get to their activities, making sure that they're getting to school and got to have enough time in the morning to make their lunch. Time is always on my mind. But I think that, I'm entering what I think is a new phase of my life right now.
Do tell.
I in the last, I would say 2 years, I have felt that I've really tried to make people and connecting with them and my own personal life day-to-day experience as valuable and as meaningful as possible. When I look back on the last 20 years of my life and my career and the lives of my children, I feel like it's gone by oh so very quickly. And I think a lot of that is simply because I have done the same thing day after day, trying to do the right thing, get up at a certain time, get the kids ready, and doing, that routine and that monotony lends itself to the passage of time very quickly.
Mm-hmm.
And so I am trying to have new experiences for myself, enjoying new experiences with my children, enjoying experiences with my parents, because their time is limited as well. I am really trying to make the most of every moment of every day, because I think now more than ever, I recognize how time is that one commodity that we will never get back. And, even with me going to our last college reunion this past year, our reunion, it's the first one I'd been to. And that is part of my journey into an era of doing new things and doing old things differently.
Yes.
So for me, time and I are working on our relationship.
Now
It's been a struggle, but we are.
can we extend this to your professional experience? Because I was actually very intrigued. Harvard Business Review released, they'll put together these compilations of articles, and it was on the toxic workplace. And I clicked, put it in the cart, add to cart, because I'm hard pressed to meet any person in medicine who's in the caregiver role who does not feel that this is now or has been for quite some time a toxic workplace. As you have this personal mission, do you feel that there is pushback from, and I'm not speaking of any institution, I'm speaking more philosophically in terms of your role, is there pushback from the demands of your profession on this dedication that you have to doing things differently and viewing time differently?
Absolutely. So I was in the medical director role from 2008 since 2018, and I would say right around 2022, the end of that year, I really started to feel a lot of pressure and a lot of what I thought was unnecessary stress from the system.
Mm-hmm.
I had taken on a lot of responsibility without the type of support that I thought I needed to really realistically attain some of these goals. And it was that lack of support that really sort of started pushing me in a different direction. I think every year hospital systems seem to have more and more metrics that they want us to meet. Well, let me say this. So I think the hospital, the patients, and the payers, those are kind of what govern my world.
Yes, those are the stakeholders.
Yes. And so the hospital wants more and more metrics met in a certain time frame. They want you to accomplish more. The patients have become, at least in my experience, have become more demanding in that they will come to me literally with an outline
Mm-hmm.
of the anesthetic I should give them.
Absolutely. Or they just don't have confidence in your medical training.
Right.
Where in the past patients would maybe look something up on the internet. But once you had a conversation and they realized the investment that you made, that you continue to make to be an expert in your field and to be proficient as a physician or an anesthesiologist, in my case, a surgeon, there would be that place of meeting, coming to yes from by both parties.
Mhm. Mhm.
And what I'm observing now is that there's almost, I hate to use the word because it has a very negative connotation, but even amongst physician patients, there's like a belligerence. Like, oh, should I trust you? Maybe I need to find someone else. You're saying something I don't agree with, but yet this is not your training, not your expertise. So there's a body of information that I'm aware of that you might not be aware of. I'm trying to make the case as best I can. But at the end of the day, even, they may defer, but then moving forward, they might say, well, you made the wrong decision.
Yeah.
I never agreed with you. I'm not sure if I'm explaining well what you're experiencing.
Yeah, I mean, I totally agree. Even when you have patients whose spouse or significant other is a physician, and I've had patients whose physician partners have come running into the recovery room, insisting that their, partner was suffering from some condition that you didn't diagnose post-operatively, and now they're having a problem. And literally they call 911.
Oh my
I
gosh.
Yeah, it's and I kept trying to, help this person kind of understand, like, no, we've got a handle on this. This is what this is. I know that you may not see this in your field all the
Yes.
time, but this is what this is. But, they don't want to listen to that. And then you feel a certain amount of pressure because this is also a physician. That they might make a complaint to somebody. It's there's a lot of pressure coming from so many directions that I think that it's become less enjoyable as an art
Yes.
form than it used to be. And so we found ourselves trying to please the hospital, trying to please the patients, and then the payers they don't want us to, perform certain tests or do certain things, and they want to compensate you less and less every year for what you
Yes.
are doing.
Yes.
So to me, I started to think, where is the joy in this? Because I genuinely love what I do. I genuinely love looking at a system and finding ways to make it more efficient. Numbers are constantly running through my head about, oh, well, this costs this much. We're not going to do this. We're going to use this one and this, constantly. That's just part of who I am. So it happens naturally. And so I have this natural desire to want to help the system and make things better and provide better care. But I find that there are just so many forces sometimes that take the joy out of it that it
Yes.
almost makes you not want to do that anymore.
Well, or how long is this the sustainable model?
Right.
We're human beings, and that I think gets missed a lot. Not only are we human beings, we're human beings that, as you say, made the decision to go into medicine because of a passion for our niche, with a passion. And that passion allowed us to defer compensation. So we paid somebody else. We paid our institutions to go to medical school. Then we accepted very low salaries for residency. Things have changed now, but when we were training, we didn't make very much.
Right.
And so we were at least like 8 or 9 years on average in before we actually made a salary that was commensurate with our level of education. And one doesn't make that decision lightly. That decision was made because we believed in the higher plane of what physicians can do. And then you find yourself now in this ecosystem, this environment where, as you say, the payers want you to give your all and do everything on credit. And they're not going to pay, what they used to pay. And your patients are, you know, not all, but many, questioning your expertise, your genuine desire to treat, and systems. now are very much concerned about quality and metrics to validate that quality, and it sort of leaves us in this mire of doing all the work without, as you say, the support necessary.
Yeah, and not even, just the support, but at least in my circumstance, I have found the lack of respect. I think
Mm,
particularly for me as a woman of color, as a Black woman, I think that you are constantly fighting for respect. There's another battle that we constantly have to fight in just even the daily, at times daily microaggressions. There's always this underlying battle that we're fighting that I don't think everybody has to fight. And it makes it, just another layer on top of what is already
yes.
a very challenging situation. You have to make sure, I think for me as a Black woman, I have to make sure that I constantly exude grace
Yes.
and being thankful and being pleasant and always, at times you can even be faulted for giving an opinion
Mm.
in a very polite and, what I consider to be a very normal fashion. But
Yes.
if someone disagrees with that opinion, you can be accused of certain things. And this is actually the first time in my life
Mm.
that I can honestly say that I have experienced firsthand the type of the types of challenges that I think are based on the way I look.
Mm.
I have not experienced that in my life before. And I think it's really, I am in a very conservative area.
Mm-hmm.
I do work for a very conservative organization. And I think that others have been shown a lot more respect and have been extended grace and,
Mm-hmm.
and, and not taken advantage of in the same way
Yes.
that I have felt that I have been simply because of the way I look. And
Yes.
I don't want to I've never been someone to run to that as an excuse or a reason. I never grew up thinking that that was a limitation in my life.
Yes.
Never. I never thought that. I never had a conscious thought growing up that that was a limitation until the last, I'd say, 3 years of my life.
Yes. The world is changing.
Yeah,
The world is
absolutely.
changing. And, I haven't experienced it, but even, my husband has begun to experience it where, he takes orthopedic surgery calls, so trauma call. And there was a patient that was requesting surgery. And she was a nurse from California. We're bi-coastal here. I'm in New Jersey. Monique is in California. And she wanted to have her elbow fracture taken care of. She wanted open reduction internal fixation, which means going to the operating room and putting in plates and screws. And he was available in the facility. And he said, well, I could do her surgery next. And the pushback that he got for simply wanting to make the hospital look good. The patient came to the hospital because that was a trauma hospital, because that's what they do. And it was all about, well, is this an emergency? You know, why do you have to do this case? Is this an emergency? No, as you say, no respect for the profession. And again, this is not just any hospital, this is a level 2 trauma center, meaning that that's what they do.
Right.
That when there's trauma, that's what they do. They take care of it. They don't send it to anyone else. They take care of it. So, you have to ask yourself, what are the factors? Why am I not being respected? Why can I not do my surgeries? Why am I always having to wait for someone else to go first? Why not
Right.
me first?
Right.
Why can't I go?
And I can say this, something similar is that, I've had patients tell me, oh no, you're not going to be my anesthesiologist. I
Mm.
need someone else. I
Mm.
need someone else. I've had surgeons say to me, well, not say to me, but one day I was looking at a chart. This is when we still had paper charts.
Yes.
Looking at a chart, and the surgeon went to the charge nurse to complain, why is the transporter looking at my patient's chart?
Mm-hmm.
So the charge nurse went running around looking for the transporter who's got a chart, and it was me.
It was you.
It
I
was
think we
me.
all have a transporter story.
Yes.
We're all patient transportation at one point in time. I remember
Yes.
as a resident, I did my training in an equally affluent area in the Upper East Side of Manhattan, and I'm standing there as the chief next to my junior, and I kind of walk like a chief, like I can be a little
Mm-hmm.
haughty when I want to be, and so the patient automatically looks at my junior, who's male,
Uh-huh.
and Caucasian,
Mm-hmm.
and begins to ask them if they're the ones that are going to do the shoulder reduction.
Mm-hmm.
And asking them about the details. And he was so cute. He's like, well, I think you need to ask my chief. I think you need to have this conversation with my chief. And, I think we all have those stories.
Yeah. I mean, when I first joined my group, I was working at a hospital, and the lounge, the surgeons and anesthesiologist lounge connected to the men's locker room.
That's unusual.
Yes, yes, yes. So I was in the lounge, and I could hear the conversation happening in the men's locker
Oh
room. Now,
my.
I had been there maybe a week, maybe. And I could hear the conversation about, what is she doing here? Why is she here? Where did she come from? So, I mean, from the minute I got here, I felt like it's been an uphill battle. But I think the last few years have really just have really been tough. Really been tough, and made me understand, some of the complexities that I have only heard about
Right.
prior to this.
Yes.
Some of the other things people have experienced, the other stories people have told, I just had not experienced that. But these last few years, it's been tough.
Mm-hmm.
It's been tough.
Mm-hmm. It's powerful. And, we want to end on a hopeful and positive note. So, as you make these plans for the future, what are your aspirations in medicine? What is it that you're looking for?
Right now, I'm looking for peace in
Mm-hmm.
my life.
Mm-hmm.
I am looking to peace and happiness. I mean, those seem like such simple things, but they're so very elusive.
Mm-hmm.
Right now I have stepped down from that position
Mm-hmm.
as the medical director, and I am actually looking to do some cosmetic
Mm-hmm.
work for a cosmetic surgeon in addition to
Mm-hmm.
working for a surgery center. But the bigger thing I want to do is to develop my own med spa.
Mm.
Yeah, and I'm actually going to do it with one of our classmates.
Nice.
So we are in the process of really trying to develop, and we've got some other things in the works that maybe at some later point in time we can talk about.
Yes.
Um,
Yes.
but yeah, we're talking about really developing something pretty interesting and cool, and really making a place of peace for us, peace for the patients, collaborating with some other people, and really just trying to take more control of our lives, and not be dependent on the hospital system, not be dependent on insurance and payers, and really just being able to become more fulfilled in that way. I think
Yes.
anesthesiology, you are very dependent. You're dependent on surgeons because you don't go out and get your own patients. You're
That's right.
dependent on the surgery center having you there. So you're very dependent on other people. And with that, comes certain obligations that you have to be able to or be willing to undertake it. You've got to defer to whenever it's good for them to do the surgery. You better just be there at that time. You have no control of when it's going to happen and when it's not going to happen. And so I want to kind of take some of that back. I
Mm-hmm.
think that I will never leave anesthesiology because I do love it. I think actually working at the freestanding surgery centers I love that. It's a lot of fun for me. I feel very much at home in that environment, which is actually what I had done prior to becoming the medical director. I was in freestanding surgery centers, and so now I'm going back to that and just looking to just trying to make my life whole.
Yes.
With a little more control. And I think it's very possible. I think for all of us, when you go into medicine, when you go into any field really, there are going to be compromises that need to be made. But as long as you still have a love and a passion for the field, as long as you have patience, patience meaning like you are a patient person.
Yes.
If you have
yes,
patience
yes.
and you believe in delayed gratification, I think that you can find that happy place for yourself. But it will be incumbent upon you to find that. Sometimes it takes a little effort, and you can't be afraid of that. So I am so very grateful for my education, for the people in my life, for people like you in my life.
Oh, thank you. I'm grateful for you too.
It's the people that have made all the difference and given me strength. And I think that, we all eventually find our happy place.
Yes. Well, on that note, I want to thank Dr. Monique King for joining us for this episode of UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart, and I look forward to speaking with you next time.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at E. Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.